Good day, I am Dr. Teke Apalata, and in the second part of this lecture on congenital infections, we are going to discuss congenital syphilis. So let me just share my screen with you. So I said that we are going to discuss congenital syphilis, and what I want to say first is that syphilis in general is a sexually transmitted disease, and it is caused by a spirochete called Treponema pallidum. And it is estimated that between 2.5 and 17% of all pregnant women in sub-Saharan Africa are infected with syphilis. So that's the statistic from sub-Saharan Africa, and also about 500,000 of all pregnancies occur in women with active syphilis every single year in sub-Saharan Africa. And maternal syphilis confers an extremely high risk of complications, you know. In a recent meta-analysis study done, it was found that about 53 to 82% of women who have been infected with syphilis, but unfortunately were untreated, had serious adverse complications or serious adverse outcomes as compared to only 10 to 21% of women without syphilis. So if a pregnant woman is infected with syphilis, the risk of giving birth to a baby with severe complications of syphilis, of a baby being infected with syphilis with severe complications, it's extremely high. Neonates who survive with a congenital syphilis are at a risk of a range of severe conditions. So some will be born with a low birth weight, and others will be premature, and most will have congenital abnormalities, and there are some who will actually develop active syphilis themselves, and we will have a good proportion who can be born with long-term complications that will involve bone complications, neurologic complications, you know, hearing problems. Now, how does the transmission of congenital infection happens? The transmission occurs through the placenta. It means that this spirochete, Treponema pallidum, will then pass through the placenta from the mother to go and infect the unborn child. However, the risk of transmission to the fetus depends on the stage of maternal infection. So if the pregnant woman who is untreated is infected with syphilis, that is at a stage that we call primary or secondary stage of the disease, 25% of the children will be stillbirth, and 14% might die at a neonatal age, and 41% will be alive but infected, and only 20% of the children might have the chance of not being infected, you know. So this happens when the mother's stage of syphilis is at a primary or secondary stage. But if the mother is at a late syphilis stage, in this situation, you know, 77% of the children will have a chance, of the mother will have a chance of giving birth to a child who is not infected. So the risk of your child being infected if you are pregnant is extremely high if you are at the stage of primary or secondary syphilis, because there, especially during secondary syphilis, the disease is disseminated, but during a late syphilitic stage, the disease is much more localized, in certain organs, mainly the heart or the brain. But during primary or secondary syphilis, chances are very high that most of the majority, almost 80% of the children will be infected in utero. Now, women whose infection manifests itself during the first year after delivery may also infect their infant. So in terms of clinical manifestation of the condition in children when they are younger than 1 year of age, the clinical manifestation depend whether the children are still younger than 1 year of age or they are above that. But here, when they are still very small, younger than 1 year of age, I spoke about stillbirth, or they can be, the delivery can be done prematurely, but they can also have a lot of reticuloendothelial presentation, like they can have a generalized non-tender lymphadenopathy, they can develop anemia, they can have leukopenia, they can have thrombocytopenia. It means that the hemoglobin level can be low, so the white blood cells count can be low, the platelet count can be low, but they can have what we call hepatosplenomegaly, so they can have a bigger liver, a bigger spleen, so those are reticuloendothelial manifestations, but they can also have mucocutaneous manifestations. They can have some skin condition that we call mucus patches. They can have a maculopapular rash. They can also have at a perioral and perianal area, they can have a condition that we call condyloma lata. Condyloma lata is very specific for syphilitic infection. They can also have a skeletal deformities that mainly involve long bones, long bones in lower extremities that are highly affected. They can also have other bone-related deformities. 40 to 60% of these children will have abnormal CSF, so they can have problems, neurological problems. They have ocular problems, their eye can be infected, and others can have many other complications. So you will see that those children will be born with a lot of complications. But if the children are older than that, they might have many other clinical complications or manifestations, but the most important is what we call Hutchinson's triad. So it means that they will have high likely develop those three things that we call Hutchinson triad. It means that they will have an eye problem that we call interstitial keratitis, and they will have deformities in their teeth that we call Hutchinson's teeth, and they will have a hearing loss, so they will have problem hearing. So this is the triad that we call a Hutchinson triad. So we have here we have interstitial keratitis, that is a non-ulceratic lesion due to an inflammatory response, and that might lead to the opacity of the cornea, and that the child will present with. And Hutchinson teeth, you will have a specific teeth deformity that you can see here. That's what we call Hutchinson teeth. And in addition to those two problems, the child will have hearing loss, so he will not be able to hear anything. Now, how do we do screening for syphilis first during pregnancy? There are two categories of serological tests for syphilis. The first category is what we call a non-treponemal test, and we have two types of non-treponemal tests that we do. We have a VEDERAL, that's Venereal Disease Research Lab. So that's one type of test. We also have another one, what we call a rapid plasma reagent test, so RPR test, that detects the specific antibody to cardiolipin. And a second category of tests are what we call treponemal tests. So non-treponemal tests are non-specific tests, and treponemal tests are specific tests. Remember that the cause of syphilis is called treponema pallidum. So non-treponemal tests and treponemal tests. Treponemal tests, we also have those two categories. We have fluorescent treponemal antibody absorption, and we have a microagglutination assay, treponema pallidum. So those are also the two types of treponemal tests that are commonly used. Now, let's look at briefly non-treponemal test, or we call NTT, non-treponemal test. The principle of this test is that the non-treponemal test determine levels of IgG and IgM. Remember, IgG and IgM are antibodies. They are immunoglobulin G and immunoglobulin M. So when you are exposed to an antigen, a pathogen, you have to develop antibodies against that specific antigen. So those NTT tests, they look for the presence of those antibodies, IgG and IgM. Those antibodies are against the cardiolipins. Cardiolipins are not true antigen from the treponema, but they are surrogate for treponema pallidum antigens, And we do that by doing a flocculation-based method, and flocculation-based method to try to look for the presence of antibody against the cardiolipin that are just surrogate from treponema pallidum antigen. And the assays that we have can be either qualitative or quantitative. It means that the qualitative can just say maybe it's reactive or it's not reactive. But quantitative, you can be able to measure the titer. You can know the initial titer. Let's say this was the titer, and when you start the patient on treatment, you can actually, if the treatment is working, you can see that the titer is going down. So the advantages of using those non-treponemal tests are numerous. One is that they will help in determining the disease stage. Okay, they can be able to tell at which stage of the disease the patient is, and they are very, very important in order of monitoring, the response to the treatment, especially the quantitative assay. So before you start the patient on treatment, the titer, so the levels of antibodies, then you can start measuring over time to try to see the response to the treatment. And most importantly, all of them are cost effective, especially they are highly applicable in small laboratories where they don't receive high volumes of specimen. But there are a lot of disadvantages also associated with non-treponemal tests. The first one is that they can give you false negative results. And the false negative results, especially during early primary infection, just at the beginning of the infection, the result might be falsely negative. Or during late latent syphilis, the result might also be negative. And in patients who are partially treated, their infection is partially treated. Maybe they receive some few doses of penicillin, they did not complete their treatment, so they can be partially treated, or they receive any other antibiotic beside penicillin, and they could not finish the course of that antibiotic. And the other thing is they give you what we call a proson effect. The proson effect is a false negative result due to high titer specimen unless diluted. It means that when you receive the blood specimen, you extract the serum, you measure the titer, and if the titer is very high, it means that there is a high number of antibodies, the titer is extremely high, and because of that, you might have a negative result. And that negative result is actually a false negative result. What happened is that because from the clinical information, you highly suspect syphilis in this patient, what you have to do is to dilute that serum. When you dilute it, you repeat the test, you will see that now the test will become positive. So this is what we call the proson effect. The other thing is that you can have a false positive result, especially if in pregnant women, you can have a false positive result in pregnant women. In patients with febrile illnesses, connective tissue diseases, tuberculosis, leprosy, some of them can give you false positive result. Now, beside the non-treponemal test that we call the entity test, we have the TT test. Those are treponemal tests. And the principle of this test is that they will determine levels of IgG, either IgG or IgM, against treponema pallidum antigens. Now, those are very specific tests because they are looking for antibodies against treponema pallidum itself. It can be the wall cell of treponema pallidum, or it can target specific antigens derived from the treponema pallidum cells. You know, and here we use either agglutination or fluorescence or immunoassay method. Remember, for the entity test, we use flocculation, but here we use agglutination or fluorescence or immunoassay method, you know, and those are very specific, and non-treponemal tests were non-specific. The advantages here are that antibodies detected by treponemal test assays arise early. So those are able to detect, to pick up the infection early. So most of those tests can be highly sensitive, and they are also highly specific because they detect specific antigen, treponemal pallidum antigen. So they are highly sensitive and highly specific. And also those TT assays detect antibodies that are missed by NTT assays. You know, we say that one of the limitations of non-treponemal pallidum assay was the fact that they cannot pick up early primary infection or late latent syphilitic infection or partially treated syphilitic infection. But treponemal tests, specific treponemal tests, are able to pick up, you know, to pick up all those missed infections by non-treponemal tests. But they also come with their disadvantages. One is that reading FTA test, one of the type of treponemal tests, can be subjective, and occasionally it can lead to false positive results due to non-specific fluorescence, especially if you do a fluorescence test, you know, and they can come with a high initial cost because some of those tests can be automated, and the machine can be costly, the equipment, the cost of purchasing and setting up the equipment can be very high. And that's why most of those tests are limited to research settings or to the big academic laboratories. And there are also difficulties in differentiating sometimes between past and new infection. Now, the following should be noted. One is that gestational syphilis is diagnosed most commonly by routine serological screening of all women during early pregnancy. So when pregnant women come during their antenatal care visit, they must be screened for the presence of syphilis, or to try to exclude syphilis in those women. So women who are at a higher risk even for acquiring syphilis during pregnancy should undergo repeat testing, especially during the third trimester, and even at delivery, they can again be screened to ensure that we are not missing anything. And women who did not receive prenatal care should have maternal syphilis serology performed before they are discharged. After giving birth, if they did not follow antenatal care, then they need to be tested. And what we should avoid is that to collect samples from cord blood. This is not recommended. And the other thing that we should also know is that women may also present with signs and symptoms of primary or secondary syphilis in pregnancy. That will warrant serological examination at the time of their presentation in the facility or during antenatal care visit. A diagnosis of maternal syphilis during the year after a woman gives birth should lead to testing of the infant. So if maybe a woman gave birth recently, then you found that the mother is coming back with signs and symptoms suggestive of syphilis, we need to call back the child so that we can investigate if we did not miss the infection. Okay, so there are antibodies that can cross the placenta from the mother to the child. And those antibodies, usually, if you pick them up when you try to investigate, to screen the child, if they came from the mother, if they are not the result of the child or an infection, then those antibodies will disappear, in an infected infant. After 6 months of age, most of them will disappear. But especially if the test was done using a non-treponemal test, all antibodies in the child done using non-treponemal tests, entity tests, and if they are positive, you must know that they might come from the mother. And as a result, if they indeed came from the mother, they will disappear after 6 months. But if you picked those antibodies using specific treponemal test, and if those antibodies came from the mother, they will only disappear after 12 to 18 months. Okay. So how do we go about this? First, we can do both non-treponemal and treponemal test in the pregnant woman. We do that. And appropriate treatment, if it's positive, we can put the mother on appropriate treatment. Then we can repeat the test. And when we repeat the test, if we found at least 3 or 4-fold fall in a maternal RPR titers, it means that when we do the initial test, we have the titer here. And if the titer falls, by 3 or 4-fold fall after we repeat the test, after putting the pregnant woman on treatment, and the child RPR is found non-reactive, there is nothing we can do. So we can just observe, or we can repeat, the clinical and serological examination between 15 to 18 months of age, on that child. But usually, if you diagnose syphilis in a pregnant woman, you put that woman on treatment, you repeat the treatment sometimes later, you see that there is a decrease in the titer, 3 to 4-fold decrease, and the child who is born is not reactive, so you don't do anything, you just follow up. You retest again after the child is between 15 and 18 months old. But if you found that the mother, when you repeat the test, the titer, you find that the mother has 3 or 4-fold fall in maternal RPR titer, but the infant RPR is reactive. But if the infant is asymptomatic clinically, you still don't do anything. You just observe and repeat the examination when the child is between 15 and 18 months old. But if the infant RPR is 4-fold higher than the maternal, or the infant is symptomatic, then you need to do a full evaluation for congenital syphilis in that child. It means that when you take the maternal test, you do also the test for the infant, and you find that after you find that the infant RPR is actually 4-fold higher than the maternal titer, or you found that the child is clinically symptomatic clinically, then that will require a full investigation to try to diagnose the presence of congenital syphilis. Or if you notice that there is an inadequate fall in the maternal RPR titer, because we are aiming that after treatment, the maternal titer should fall at least 3 or 4-fold down. But if you found that maybe it's just 1 to 2-fold in the titer, then it's inadequate fall in the maternal RPR titer. So that child will still require a full investigation, So this side is that if the mother receives inadequate treatment or not adequately documented treatment, so it's either there was no treatment or non-penicillin treatment. If the mother did not receive penicillin, receive any other medication, other antibiotic, we qualified it as inadequate non-penicillin treatment. It's inadequate treatment. So the child, the baby, will then go through full evaluation for congenital syphilis, including examination of the long bones and the CSF examination. And here, it doesn't matter the outcome of this examination, whether the patient is asymptomatic and CSF and long bone normal, or the patient is symptomatic, they need to be treated for congenital syphilis. Okay, so a presumptive serological diagnosis may also be made, one, if the infant non-treponemal titer is 4-fold higher than the mother's titer. So you can make a presumptive serological diagnosis of congenital syphilis. Or if the infant non-treponemal titer persists or increases after birth, instead of it disappearing, the antibodies disappearing, but it persists or it keeps on increasing, it is also a presumptive serological diagnosis. Or if the infant treponemal antibody titers remains positive after 12 to 18 months of age, that's also a presumptive serological diagnosis for congenital syphilis. And in a resource-poor settings, tests might be restricted just to use RPR or VDRL. So this test, we say, detect IgG, which is transferred, that can pass from the mother to the baby through the placenta. So therefore, it is always important to compare the result of RPR from the mother and from the child when he is born. So we said that if the result of the titer from the child is 4-fold higher than the mother, then it is an indication of an infection. Or if it persists, after birth, over 6-month period, it is also an indication of a syphilitic infection in the child. So the treatment protocol for congenital syphilis, it's actually based on the use of penicillin. So all symptomatic infants will receive IV or intravenous or intramuscular crystalline penicillin G. So they will receive 50,000 units per kg every 12 hours for the first 7 days of life, and then every 8 hours after 7 days of life for a maximum of 10 to 14 days. The alternative treatment here is intramuscular procaine penicillin G, 50,000 units per kg as a single daily dose for 10 to 15 days. But when you are dealing with a symptomatic infant who are at least 4 weeks of age or older than that, we can use aqueous penicillin G, 50,000 units per kg per dose every 6 hours intravenously for 10 to 14 days. And in asymptomatic neonates born from RPR positive mothers, they can receive a single IM dose of benzathine penicillin G, 50,000 units per kg can be given to these children. And we will then do a serological follow-up. We can do the follow-up of children with a congenital syphilis. We will do serial non-treponemal serology done after 1 month, 2, 4, 6, and after 12 months. So we follow them up to 1 year or 18 months. So remember that non-treponemal antibodies can disappear after 6 months, and treponemal antibodies can only become non-reactive. Tests can become non-reactive after 12 months, but sometimes they can persist until 18 months, then they will disappear. So children with a persistently positive titers, even at a low level, should be considered for the second course of treatment. And infants with treated neurosyphilis, those who will have their brain affected because of the condition, and they develop what we call neurosyphilis, they should have a repeat cerebrospinal fluid examination at 6-month interval until the results are normal. So we repeat the test every 6 months. We do the CSF tap, we test until the result become normal. A positive CSF VDRL 6 months after the treatment require, again, a second course of treatment. So after repeating the test, after 6 months of treatment, if we do a VDRL test again, it comes, it is abnormal, it's still positive. We need to repeat the course of antibiotic for the second time. Children who are uninfected should also have serial non-treponemal titers, which should become non-reactive, we said, after 6 months. Now, in summary, what can we remember from here is that all pregnant women should be tested for syphilis in pregnancy, and women at a higher risk for acquiring syphilis in pregnancy should be retested at the beginning of the 3rd trimester, mainly at 28 weeks, and also they can be tested at delivery. HIV testing is particularly important in women with positive syphilis serology. Penicillin is the only antibiotic proven to be effective in the management of gestational syphilis, and children born to mothers treated with a non-penicillin regimen should be considered to have been treated inadequately. And the diagnosis and the management of congenital syphilis should be based on maternal history, clinical findings, non-treponemal test. It can be VDRL, mainly on CSF, and RPR on blood, and treponemal test that can be either FTA or MHA, and test to identify definitively infected infant at birth, such as IgM and DNA detection using PCR molecular techniques, are considered. So with this, we end this presentation on congenital syphilis. So you can post your questions in our channel. We will respond to you, send your comments and your questions, and we will be able to attend to that. Don't forget to follow our first part of these congenital infections. We spoke about toxoplasmosis, congenital toxoplasmosis, and the second part we are talking about congenital syphilis, and the next one we will speak about rubella. We will also speak about herpes simplex virus in children, and we will also speak about cytomegalovirus in children. Thank you very much. Bye for now.